taking all my signs. Ding, ding, ding. Give me a second. Ding, ding, ding. Is she ready? We don't have a bell, so we got to beat on the table here.
Hello, America. This is almost like trying to get the Commissioner's Court. Almost.
We are worse.
Oh, I didn't see you, Commissioner. I'm sorry.
Okay, well, welcome everybody. Glad to have you guys here. And we're going to get right to some presentations, I think, aren't we? Yeah.
Yes.
So I think Greg and Sam are going to give us some more interesting data today to help us. So
I think we're getting into the meat of our
Yeah.
deliberations now. So this is good.
Good quantitative meaty stuff. Absolutely. All right. Let me turn this on. Yes. Okay. There we go. Am I picking up?
Hope so.
are we?
All right. Well, thank you for having me back. As was the case before, there's a big team behind this. So appreciation for many for that. Any mistakes or overly complex charts, I'll take the blame for those. But as I introduced myself last time, Greg Vaishon. I'm a physician in internal medicine. I see patients on the south side of Chicago at a FQHC. I've been with HMA for 9 years, working in primary care and integrated delivery system engagements with HMA, who HMA is a consulting firm that focuses on publicly financed healthcare, both on the payment side of it, the delivery side, policy, the whole shebang. Today, if there's questions as we go through, please stop me, and we'll go through those pieces. This is, as you were saying, kind of the meaty quantitative part. So I want to make sure that we lay a good foundation here. It's about system capacity, the system's ability to meet the needs of a population. So we'll define each one of those. But wanted to start with key points. And this really carries through from the delivery system talk from last week. And the first one is really that the needs of the population. So as we define the population, there's the whole Tarrant County, and we'll go over this in a second, and then there's target populations under 250% of the federal poverty limit, or even more targeted, the connection eligible population, which would be those over 18 in that bucket. The needs of that population far exceed the capacity of JPS. So we'll see that throughout these numbers, and that's seen in a lot of different ways. And boarding at the ER, people waiting to get up from the ER into inpatient rooms, not being able to get primary care appointments from the emergency room out to outpatient centers, even in some downstream stuff, right, where later stage cancers. And so there's a lot of kind of effects of that first statement, which the needs of the population are far beyond the capacity. And that capacity couldn't, it's so far beyond, that capacity couldn't be brought all the way up to meet all of those population needs. And that theme came out last time in the delivery system talk. And it will need to be met partially through system transformation, which can mean a lot of things. It can mean across the county, partnering, building an integrated behavioral health delivery system. That it can mean things like care management, care transitions from the hospital to outpatient. It can mean technology, like having home monitoring for those high-risk patients so they can get out of the hospital sooner and stay out. So it means a whole lot of things, but transforming the way that we talked about e-consults last time, transforming the way that the care is delivered so that the capacity is increased and hopefully needs reduced. And the third point is part of that. It's part of that transformation, but it's a key part. It's kind of a foundational part, which is the primary care and prevention efforts, which really reduce It's an investment now to reduce in the future the needs of that population. So reducing people coming into the ER with later stage or ambulatory sensitive conditions, or even from getting some conditions in the first place. So these are the key points as we go through the numbers that I think come out from those numbers. If you've read that whole report, there is a lot of numbers there, a lot of tables, and it can be kind of confusing to say what does this percentage mean and what exactly are we talking about. And so this here is going to take us through one example that's a framework of how the rest of it is written and reported. So it's one example. There are some differences in different parts, like in the primary care and the behavioral health, but it still follows this general framework. So it's good for us all to be on the same page on this. So the first thing this box represents is the entire Tarrant County population, 2 million people right now. And we can, by looking at other systems in the U.S., Medicare numbers, the CDC ambulatory care survey, we can estimate how many, for instance, how many cardiologists would be needed to serve 2 million people, given our current day health system. And that's about 80 cardiologists. If you look deep in the pages and the methodology, et cetera, there is a little more cardiologists than that in Tarrant County right now. So as a whole county, there's adequate specialty care. And that's a theme not only here, but in other places in the U.S. If we go to the need for the target population, that's a smaller slice, right? That's now under 250% federal poverty limit. And there we can say, based on the distribution of those over 65 and those under, that about 30 cardiologists would be needed for that population. We can take that out, and we're going to be looking at that generally as a population itself, not at the total, although we will for primary care. And then we can put up against that the JPS capacity, meaning, okay, the FTEs that are at JPS, what proportion of that total population need, the target population need, could those cardiologists fulfill? And there's 8, and so it's about 26%, somewhere around there. So a big difference between the total population need and the capacity of the system. Clearly, other systems are have cardiologists and see people and patients from within this population. So other systems are filling in some of that need. Unfortunately, some of that goes directly to the emergency room or directly to the hospital, and not through an organized system of care. But nonetheless, some of those needs are being met by other systems. And that's an unknown amount, put an approximation. And then there's a block of unmet needs. And we know that's the case just because of how far off this is and the, what we heard from stakeholders meetings and what we saw in the waits to appointments. So there's lots of evidence that there is a big block of unmet needs there. So significant unmet needs in the population, even though for some of these, for most, there is adequate specialists throughout the whole county. But we have another thing going on. You have another thing, which is population growth, significant population growth expected. So this is now, and kind of that story that we looked at. And then what is inside the report is just saying, okay, so if the system stays at that level of 26% of need met, what would that mean based on the population changes expected over this time, which is a little greater growth in the over 65 and requires more specialists and more acute beds. And we can see there that that's going to equate to somewhere in the range of 3 cardiologists, and that's in the report as an exact amount. But there's an amount there that gets you up to, serving the same percentage of the population. And in that scenario, we can see that the absolute unmet needs, right, the size of that red box, is getting bigger over time. So more stress on the system and on other systems.
And just to make sure I understand, this is for that target population, right?
This is for the target population, absolutely. Yep, yep, target
And
population.
of that target population, what do we estimate that percentage as being uninsured right now?
It is, so this is, on the target population, we're talking about those that are 250% under FPL. It's a significant number. On the JPS Connect, it excludes the Medicaid, but on the total FPL, it includes the Medicaid. I'd have to get back to you on the exact percentages,
Yeah.
but it's a significant percentage of those that are uninsured at this time, particularly the
reason why I
Medicaid
asked-
under or uninsured.
The reason why I ask, Greg, is just because you mentioned that the other systems take up some of the slack.
Yes.
And of course, that's probably 90% through their emergency rooms, I would think, which for that first critical event,
Big
as,
portion, yep.
as opposed to preventative type things that could keep them out of the ER, right?
Yep, yep.
Yeah, okay.
An organized system of coming through primary care, getting to the right
Right.
specialist at the right time, and getting those events
Yeah.
taken care of.
Lorraine?
There's some,
This does not include undocumented either.
this does not, right, that's right.
So
It's about,
will the other systems accommodate a lot of the undocumented also?
yes, in that sort of unorganized method of getting care. And I,
Like through
heard
the emergency
stories,
room?
Right.
yeah,
right.
heard stories from stakeholders of, being unable to get care, some specialty care, and having to leave the county to get some care. So that certainly happens.
So then, is the target the 3 million, or the target only the indigent population? Are we, in regard to capacity, are we talking about the whole county? Or are we
Excellent.
talking about
Yes.
percentage of the county? Because I
Right.
think that helps us with our focus.
Yes, yes. Right now, we know that there's over 250% FPL patients who are accessing JPS, and that's good. It helps, it helps support the system, and it's kind of a expression of confidence and wanting to be in the system, and you want to have a system that attracts those patients. So no, I would say it's not that. But when you think about, okay, let's hang our hat on a number to say, how close are we to meeting needs? It is population of interest or target population, or kind of, how are we doing here? I would say that is important to analyze and to plan for. Even though, yes, you want to be participating in the coverage of people outside of that population.
What we're talking about right now, though, is the entire county or just that percentage?
So right here, we're talking about that percentage that is in the less than 250% FPL.
All
Yeah. And most of the report, although we do have primary care and behavioral health pieces that look at the whole of Tarrant County, it's still with the idea of informing, why the picture is the way it is for this target population.
Can I ask you one other question related to that? Is the targeted population what the county has told you is the targeted population, or something you've decided?
No, it's something that is already a significant part of the delivery of care at JPS. It's something that the stakeholders, kind of.
Well, I understand that, but has the county, as GK and his group told you that's the targeted population, or is that what you?
Actually, when we talk about 250% above poverty or below poverty, that is a policy that is driven by the board of managers at the hospital district. It has been a long-term target
That's what my question.
of the individuals that
Yeah.
they serve.
That answers the question. Thank
Now,
you.
I do want to point out one thing, though, and I think the answer to your question is yes on both of them.
Okay.
Because what we're attempting to do here is really a two-part process. We're looking at healthcare as a whole for the county, and then what part of that healthcare is something that JPS has a key role in providing.
Okay.
And while cardiologists, I don't need to take your presentation from you, but I'll do that. Cardiologists may be a specialty where you have enough to service the entire population. it is one of just a very few specialties that you have enough. And so it goes back to not only serving the indigent, but also how we look at our medical schools and producing doctors and specialists there that will stay in the community, that will service the entire community, because we'll never get to the point of being able to service the 250% unless we have more doctors in the system. And medical schools and the roles that they play and the number of doctors that they produce and the number of the ability for them to receive training at our local facilities is a big part in retaining those physicians after they finish their training.
And my rationale is, you know, how much of the elephant are we trying to eat as it concerns funding going forward? And if we are looking at the whole elephant, you know, that's still, and I'm looking at our timeline, that still is moving us farther away from dealing with the actual elephant in the room. I mean, the elephant is funding, so how much of that is going to actually be enough for us to deal with the target? So is the Board of Managers saying we are wanting to target the entire population? Well, then we know already we won't have the money for that. So then as I sit here for this 2 hours, I'm wanting to know, okay, well, how much, with all due respect, I'm wanting to know how much of this is going to be pertinent to the discussions in the future, which based upon our calendar, we don't have that many more. So I'm just trying to wrap my brain around, with all due respect, the relevance of this whole argument as it concerns funding going forward, the board's strategy on how they're going to be good stewards of that funding, and how is that going to be relevant not only to my area, but to the entire county as we talk about it, you being able to assess or have access to what you need. So if I'm dealing with the indigent population, then make me to know how we're going to help those individuals. Because we have 80 other hospitals that's attempting to deal with the whole population. But if the mission of JPS is to deal with this given group, then help me to know the relevance of the discussion. And that's what I'm saying.
Yeah,
No
I
disrespect.
appreciate
No.
Yes,
But
sir.
I think what he's saying, if I hear you right, you're saying 26% of this population is what JPS is dealing with. And what we're trying to figure out, what is the system capacity based on the other big elephant in the room, the demographic explosion that we're about to experience.
Right.
And so how can that system accommodate the 26% that we're targeting?
Yeah, and I think, you know, one of the things I'm hearing, and tell me if I'm hearing that right, is that it would feel like how could we build and hire into meeting that need of even this population.
Yeah.
I would say, you know, that's one of the things, you can go back to those key points, that you can't. It has to be part system transformation, which is partnering and organizing the care. It has to be building capacity when you see this, where you are and what the needs of the population. But it can't be the only answer. And this is one way of just looking at that visually, which is saying instead of just matching that 26% over time, to make a strategic decision, which will be different in primary care versus maybe, you know,
Behavioral.
Exactly, behavioral health, where it's really foundational in prevention, and maybe in some specialties where there is not capacity or a way of doing it at other systems, and to expand those more. So to do this strategically, not for everything, and cardiology may or may not be the right one to strategically put that focus, but to increase capacity, but it's not the only answer. It's also creating that integrated system, that way of partnering with other systems, the system transformation that allows for others to also increase their percentage that they're delivering. And instead of having those unmet needs, again, through technology and other ways to manage that need over time. And again, that can be, there's a lot of different ways to do that. We talked about e-consults last time. There's home monitoring. There's a lot of telemedicine. There's a lot of technological ways to manage that need. And some of it is through building the right capacity of primary care or prevention, is managing that need down. So I think it is, when you do take that focused population, 250% under FPL, there is a hopeful way to get there, but it's a combination of ways.
And the 26% is 26% of the target population, not 26% of the whole.
Exactly. Yes. Indeed.
What's the percentage of the total population under 250% of poverty level?
It's about 35%, something
So
like that.
JPS has the capacity to meet 26% of that 30.
Of that other number, yeah.
Okay.
Yeah.
That number is 425,701 as of today. And
That's
it's
the total?
400,
total?
it is on page 1 of your excerpt, the report, the excerpt. There, you should have another copy sent to you.
Under system capacity?
Yep. Under population growth.
Yeah, that's JPS connection eligible, 425, so it's a more restricted population than the total 250%
JPS.
FPL. It's over,
JPS connection eligible.
yeah, over
Okay,
over
I mean,
18
that's-
non-Medicaid, so.
That's highly targeted already.
Yeah,
Right.
highly targeted at 425, which is a good number to kind of say, okay, what are we doing there for that particular population?
Okay.
So that gets down to about 20% when we're there, just JPS eligible.
Page 1 is actually in the box here under population growth. This is 425, yeah.
So this is something else that you brought up about serving others in the population. So when we do say, yeah, this is 26% here, it is we need to be aware of and take into account that there are people outside of that 250% FPL that are taking it, that are seeing those cardiologists. And so what is actually there and available to meet needs of the under 250% FPL is a slightly lower, because some of those resources are being used for people over 250% FPL. So it's a simplification,
That makes
but
sense.
it's just, it's a way of describing this. Okay, so now we get down to some of the particular areas, which would be primary care, specialty, acute care beds, and psychiatric beds. Those would be the kind of areas that we cover. And this is telling us about the total primary care physicians in Tarrant County, and what the needs would be expected to be on a population basis. So one would expect that right now there's a need for a little over 1,000 primary care physicians, primary care providers. This 778 is primary care physicians. That's what we have the number for. PAs and nurse practitioners, advanced practice practitioners, are filling in some of that gap between the 75 and 100. An unknown number, but unlikely to be that whole gap. It's certainly not a third again, as much primary care. So even just at Tarrant County, there's less primary care than would be needed. And this has big implications in terms of training and recruiting and retaining. And that would be 25 FTEs, absent retirements and other pieces of people leaving being a PCP. A net gain of 25 per year. That's quite a few to retain from your fantastic family medicine residency.
Let me clarify something. When you say
Sure.
FTE, you are referring to the primary care providers, namely physician or
So this is primary care providers. That's how many FTEs you need to kind of cover that population, have reasonable panels.
FTEs.
Full-time employee.
Yeah.
I understand that,
Yeah,
but
nurse
what,
practitioners, PAs,
Oh,
physicians,
okay, okay.
that's what you would need. And now what we have is a number for physicians. We don't have the number of, so there is more. It's more than 7, how much more? Cannot know exactly how much more.
okay.
But certainly, it would have to be, 25%, it would have to be 1/3 of all the physicians, again, as many nurse practitioners and PAs. And in most places, that's not the case, and probably not here, so it's probably under. This gets to the 250, less than 250% FPL. In that population alone, 378 FTEs are needed. And right now, JPS is delivering 98 FTEs worth of primary care. That's current. And that comes out at the same percentage, and it happens to. A couple of these numbers come out pretty close to each other, but that's circumstance. 26% on the primary care side of the need being met. And to kind of continue that same coverage, right? 26%, remember we said that's one scenario where you kind of just say, okay, the populations go up, we'll keep things all the same in terms of the percentage of needs met. Just there, you're talking about going from 98 to 149 FTEs and having, buildings and places to have those FTEs over 20 years. If, on the other hand, this is a place, primary care, where there's a strategic decision that this is where you do prevention, this is where you kind of organize care, so there is less specialty need, that you're preventing ambulatory sensitive conditions from going in the hospital, and you're putting extra resources there and planning to meet a greater need. If 50% were picked as a target, you can see that there's a need to triple the number of primary care providers inside of 20 years. So a big lift, and implies really major training, recruiting, and retention of those primary care providers, both on the physician and the.
Does that take into account the retiring?
This does not. This is net. Yeah. So this is a net increase of triple. Right.
Yeah.
Right.
Can we ask Dr. Flint,
What are you laughing at?
can we
Piece of cake.
Can we satisfy this capacity, this need?
I think we could produce a lot more in Tarrant County with expansion of GME, first of all, but that doesn't mean you keep them all, but this is a place people like to live. These numbers are going to require significant recruitment from outside, which is very expensive, not totally quality controlled, and then you get people here and they don't like it here, or spouses don't like it, and so you're definitely, as you know well, you're climbing a big hill here. Yeah.
Well, if I can add one point, I've only been on the board 7 years, but there's been a philosophical change. All of a sudden in medicine, we have value-based care. So the other thing you have to think about here is reimbursement for all these people we're providing care for is based on value-based care. And let me touch on a touchy subject here in that our emergency room rates for left without being seen were huge. That has dropped dramatically thanks to the efforts by the hospital. If you will, expand how many people left without being seen in the emergency room to those who never got seen in a primary care setting, add that to the population growth, you begin to get a feeling for how far behind we are. I think everybody in this room already knows we're going to do something. How much and how far? At the hospital itself, we go across Main Street. That's for me. Tell them I'll call them back. We have the bricks and mortar problem, which we haven't even gotten to yet. We have this personnel problem. And for all the wonderful efforts to get ourselves up to a much smaller number of people leaving without being seen, we're going to go back to that again if we keep expanding because, well, we have a shortage of people.
Yeah.
So
And
if we're going to be reimbursed by all those entities that do reimburse, we're going to have more staff, and the medical schools and the Dr. Flynn hit on the point of the GME stuff. If you're not training them in Tarrant County, they may not be staying here.
Even if we had the people, we don't have the facilities to accommodate them.
Correct.
Yeah. So we've got to do more people, more brick and mortar, to accommodate.
And particularly when you're talking about value-based payments, that having a coverage of a population, having responsibility for that population, which really starts on the primary care and behavioral health side, is important.
Can you go back to slide number 5? I like picture. It helps.
Yeah, me too.
If you look at the last column, right? So when we're talking about expanding capacity, what we are talking about is hiring more FTEs and building bigger facilities, more room, right?
Right.
So we have 2 levels to deal with, because to maintain the 26% service rate of the 250% FPL population, we need so much more number of employees and so much more space. Okay, but if the board decides that we're gonna boost from 26% service rate, say, to 50% service rate, or 30%, then we will need that much more capacity.
Right.
But even if we push it all the way to 50%, we still have a significant number of unmet needs. So part of the strategy is somehow to create partnership, right?
Yes.
So that has to be on the forefront of our discussion, I believe, because each and every one of us in this room, along with the members of the Board of Managers and the members of the Commissioners Court, we are focused on the internal operation of the enterprise that we are responsible for. Who's gonna be in charge of governing this long-term partnership to make sure that we manage the unmet needs and reducing it? You see,
That's a good point.
that's the to me, that's a big elephant in the room. To me, that's a big elephant in the room.
And the
Because
money to pay for it.
how do we do that?
Yeah.
Yeah.
I
Yeah,
think
and
we
if-
should
and
check.
if- and that piece can be some money, there's no doubt about it, but it really
It's
is a lot about.
significantly less.
Yeah, significantly less, and just a slice. What it really is about is more organizing the system of care, its leadership, its organizations and institutions coming together to make plans and everyone taking a part of it, because, you know, to have this for the entire community is of benefit to others. You know, who's coming into their emergency room, how, I mean, it's beneficial to others as well.
Excuse me, I have a question, and to piggyback off of that, as far as these partnerships are concerned, is there a way, GK, that we can have maybe a presentation, talk about the current existing partnerships that are there? Because in order for me to have a full understanding of what it means to create partnerships, obviously there's some existing ones right now, right? I'd like to understand how those operate and what it would take as far as an investment to strengthen it. To Commissioner Wynn's point, I'm thinking it would need to have a substantial investment in order to support someone managing those different partnerships and also creating a system. I would think that's data, I would think that's technology. So I would really like to see or hear from someone of the current partnerships that are in place and how they communicate with one another.
I think we can provide that information. It probably would have to come from the district, because
That's
y'all
fine.
work day to day on these partnerships.
So it's, I mean, I think it would probably be an overstatement to say that those partnerships have the capacity even to meet this demand.
Thank you
I
for
mean,
that.
I just
Okay,
don't
thank you
think
for
we
saying
could make that statement and be accurate.
Okay,
But,
Good.
I mean,
Good.
Tarrant County Health, I mean, our neighbors and our partners in the medical school, it's an everyday. Our residency programs, I mean, we've got Baylor surgeons in our facility every single day. So there's a dramatic amount of partnerships.
okay.
But I think we would be misled to assume that even in the event that those partnerships were to expand exponentially,
Okay.
we still are gonna have this
Thank you
delta
for saying
to
that.
deal with.
Well, and the other thing is, the capacity there is not just the capacity of JPS, but it's the capacity of all the other hospital systems.
That's right.
Yeah, absolutely.
And Andy, to your point, you asked who's gonna govern that?
Yeah, that's
That's a big elephant in the room,
Yeah.
because who's gonna demand Baylor, THR, and HCA come under some form of governance? That's the purpose of the county hospital.
It'll never
district.
happen.
Well, exactly. I said that was the elephant in the room.
That's
Yeah.
not an elephant, that's a
That's a-
dinosaur bird. You'll never get those guys together.
I mean, you can get together
You
for,
can get together, but you cannot
you know,
build
create a governance.
something to
Yeah.
govern them.
Yeah.
It'll never happen.
And-
And
but
we shouldn't,
one-
that shouldn't even really be part of what we're doing, honestly. Partnerships, yes, but hoping for some sort of massive structure to tell them all what to do.
An
not
umbrella
one of them
to,
sign
yeah,
on.
governance.
You know,
range.
that's
No,
not possible.
But,
Never sign on.
But
Yeah.
we
But
still.
but covering
may-
a population.
But
and-
they,
and, you know, having
they
an
do
organization.
have an incentive to work with JPS.
Absolutely.
Because they're seeing their patients in every single one of the emergency rooms in our area every single day. So there's actually a reason for the hospitals to want to work with them, and there's a reason for JPS to want to work with those folks. You know what I mean?
Yeah,
So-
and there's for example, the Medical Home Network in Chicago, and there's others like this, where the hospitals themselves are governing that organization, which is covering a population, shared technology, kind of
Yeah.
shared accountability of what you need to do
Yeah.
for that
It's more like a
population.
co-op.
Yeah,
Right.
so.
That
it's-
piece of it, I think.
But
you
then,
could.
how much of that, in regard to our long-term governance strategy, are we, I'm not privy to any of that. And just, I don't know if we're working on that while we're working on this, or is there already, GK, is there already a plan in place in that regard? You know, one of the things that we saw when we were touring the hospital is we saw, one wing over here, one over there. A lot of things were piecemeal. And it caused me to ask that question, well, where was the continuity in
Absolutely.
governance? And so,
Absolutely.
and even with this, again, what's in place already, what's being done in that regard to help us to meet some of these goals?
I could be wrong.
I think that's a
I
valid
could be wrong
question.
on my assumption on this, but Pastor Evans, my thought was, once we figured out what the needs were, and then we figured out what is it gonna take, that was going to lead us down the answers of, well, how much of this are we trying to finance ourselves? How much are we gonna need partners? I think that's where you get your multi-answers to, because we all know right now, we will not have a bond package that's gonna pay for everything that Greg's getting ready to show us. We know that. And so you're gonna have that pie that's too small, and then we're gonna try to figure out, okay, now once we're through our resources, what other resources are out there? Can we partner with a THR, or a Baylor, and HCA? Or all three, or whatever? I don't know. Arlington, I think, is gonna be interesting because of the logistics there, and I don't have the answer. I don't even know what it's gonna be. But could there be more of an opportunity in an Arlington, let's say, for those partnerships? You've got all three of the systems there, possibly for some unloading, as opposed to trying to create a transportation system to JPS. I don't know, but I think we're gonna run into that when we know how big is our gap.
And you're thinking about it in terms of a population as you come together to partner.
Yeah.
This here is the specialty needs, and what we're seeing is in blue. And the reason why it's a narrower on this side and thicker on that side is because this is 0 to 30 and that's 0 to 100. So it's the same thing, but a different scale. And the blue here is what's currently available in terms of resources, and the green is what's needed, and then the red what will be needed. So you can see significant gaps across the board, variable. And we certainly in the delivery system presentation saw this, that there are long waits for specialty, and there's other markers to show that this is so. In planning for expansion and where to put resources and thought and strategically say, okay, this is where we're going to expand. It does matter whether there is more pediatric patients, say in allergy versus oncology, the amount of expansion that might make sense, what other institutions are doing and willing to do in the future, and the degree to which a particular specialty can help you attract other payers as well, and the impact of that particular specialty, which might be different in allergy versus oncology. Psychiatric beds, we did go over this last time, so this is a repeat. Karen Bhatia was here and really explained about these 70 public beds at the population health level and where that evidence came from, and that going to 35 over time, planning for that, to have a integrated behavioral health system that allows for really having less beds would be possible, seems possible, and that's where that first 50% cut comes from. And then thinking about partners taking on some of the especially less complex patients, so only building to 50%, but having those two cuts and really getting down to that number still leaves you at 37% of meeting the need for the entire population in this case. This is the entire population.
And these
down to
numbers
26%.
are not based on the 250% FPL.
They are not.
They're based on total population.
Total population.
And what's the philosophy behind that?
Yeah, so Karen spoke to that, so I will echo some of the pieces there, but that when you have all of the research and all of the expert opinion on that 70 beds was based on the total population. So the source from which those came, and some of the basis for saying that in those source materials is that people may float down into a different bracket when they have a serious mental illness, and so you're drawing from the whole population in some way for public beds in a way that's real enough,
So
and
it's a
it happens
unique-
over time.
Okay.
That's
Said another way, JPS receives a significantly larger portion of the behavioral health care need than what the 26% would represent overall.
Right.
Okay.
Well, and the reality is there is no private sector competition to this. And secondarily, the only competition to the JPS system for mental health beds is the county jail. That's tragic, but it's reality.
And Doctor, you bring up a very good point, because quite frankly, when you have a police engagement with someone who's in need of psychiatric services, there's only one place in this county
Correct.
that person's gonna go.
Right.
And that's going to be in JPS. Once JPS has them, they're really not going to, they're going to deal with that person holistically to get them where they need to be.
Yeah, and this Karen went over here, right, that we, preventing, optimizing the use of beds, getting the right patients in the right place, and then as part of the whole building inpatient capacity, because not to have that capacity results in the jail as an outcome. On the acute medical beds, basically what you have here is the idea that where you're at now, which is 2 beds, right, 2017 beds per 1,000 across the whole population, right? So we're going to get to JPS connection population in a moment on the next slide. Across the whole population, 2 beds per 1,000 is about in the 50th percentile if you look at Dartmouth Atlas, so across the country. It's a reasonable place to be. So if we start out with that assumption, kind of across the whole county, reasonable number of beds, with the population growth, that goes down to a place that's, less beds than anywhere in the country. Can you get that far? Probably not. But, you are intending to set up a system and everyone is being pushed by value-based payments to set up a system to reduce hospital stays, and they have been reducing over time. So we can expect that with investment and with the push of that value-based payment, that these will go down. That's what that second row is. An assumption of where that is likely to go. At 1.65, you're in the 10th percentile of where everyone is now. But this has been a moving target. It's going down in the U.S. It can go down here as well. But even with that assumption of really good management and the beds per 1,000 going down over time, you still need 770 more beds in Tarrant County over those 20 years. And when you look at just the last line, just the growth in the population of the 250% FPL, so those extra people that are going to be coming on board, they alone need 648 at that managed level. So a lot of bed needs. This is looking more specifically at the JPS connection, including Medicare, so over 18 non-Medicaid. And here you see the bed rate. I took it out a couple decimal points just to show you that this was analyzed for each one of those periods. But what you have is increasing over 65-year-olds, and they have a lot of bed needs, and so that's driving the number to stay relatively steady. And if you see what the bed needs are across the county, it's going from 659 to 964 over time. And what JPS kind of brings to the table now, so if we say, okay, here's the number of beds at JPS, and we multiply it by the 55%, which represents the uninsured, the connection, and the Medicare, then there's 224 beds being kind of brought to the table by JPS now, and that goes from a 34% coverage of all the needs down to 23% over time. So implying, just like on the behavioral health side, that there really is a shortage there, and there's other evidence of that, bed holding, et cetera, that there's a shortage there and that it's going to get worse without building capacity. Great discussion, but if there's some more questions, otherwise I'll turn it over to Sam, and we'll have some time at the end to do more Q&A and discussion.
Okay, thanks, Greg.
Yeah.
All right. Working, I need that. Thanks, Greg. So, my name is Sam Sears. I'm with Percival Health Advisors. We are part of the Coming team, which is doing the facility assessment. And my area of expertise, Percival Health Advisors is really a strategic consulting firm for hospitals. My area of expertise, or one of my areas of expertise, is in ambulatory network planning. So I do a lot of ambulatory network planning for a lot of health systems. Obviously, this is a little bit of a different animal given your organization and your mission. So the way we kind of break down the market and think about ambulatory deployment strategy for your system is a little bit different than how we might typically look at it for hospitals, you know, given the target population, et cetera. So that is an important consideration here. But that is what we are doing. Again, we are developing recommendations around really what should that whole footprint of ambulatory care look like all across Tarrant County, right? So you've got a lot of facilities out there today. And when we talk about ambulatory clinics, we're really focusing on what you call the medical homes, right? Those 13 or so clinics that you have out there that have physicians in there, that have pharmacy in there, that have different services in there. Focusing less on the school-based clinics. I think you've kind of got that covered, but that doesn't serve the general population. So our focus is really on those bigger clinics and what that should look like over time. We have reviewed and incorporated all those HMA physician recommendations. So that number 98 that you saw earlier today, that is a number that we are using to drive our recommendations in terms of clinic development going forward, especially in current state. So we kind of use that to size up essentially where you are today and then where you need to go in the future. So you'll see that in some of the numbers here. Today's meeting is really to provide you an overview, kind of give you a sense of what does the market look like from an ambulatory perspective. What do we look at when we analyze your market and make recommendations? How are we thinking about your market? How are we breaking it down? How are we going to get to those final recommendations? Those will come 2 weeks from now at the May 23rd meeting, so this is really an introduction to that today. And then the other thing I want to focus on is that today we're really going to focus on the primary care access piece. That really is the biggest core component of your network development. It's creating that access, creating that convenient care out in your market. We will look at specialty. Right now, really, your specialty is all either on campus at the hospital or in the Barden Road Specialty Clinic. You have some of that there. So we're going to take a look at that. But clearly, if there are going to be recommendations in terms of putting specialists out in the community more, it's going to be on a much more limited basis than it will be for primary care. You know, it might be in timeshares, et cetera, but that's something we'll talk about more at the next meeting. Finally, we'll have this wrapped up by the end of May in terms of the final report on the ambulatory network component. So, why are we doing, oops, it didn't flip over, did it? That way? I don't know if it's not a PowerPoint.
Yeah, it's not working.
No. It's not even showing that on the screen. Well, this is actually a PDF, so it's not actually what that is.
Oh, there we go.
It's working now. All right. So it's important to ask yourself why we're doing ambulatory network planning. It's really a critical component of focus, especially with population health going forward. First of all, you're creating more convenient access for patients, right? You're creating greater integration between JPS and the community it serves by getting that healthcare out to where the patients live. You're really creating a much better bond with your patients. You're increasing visibility and awareness of JPS services. You may recall from some of the earlier presentations around the community interviews, that was one of the comments of there wasn't really great awareness of JPS. Everybody knew the hospital, but not everything else. So I think as you start to build that up, you create better awareness, and I think it really enhances the relationship with your community and with your patients. This third point here in terms of contributing to more preventative care, diagnosing and developing illness before it turns into more serious, really you're supporting population health by getting that kind of care out there. So all these studies show that when you have that better access to care, when you're more involved, when that's local physicians that you're dealing with, you're more likely to do preventative care, get to the illness before it gets into something serious. And that's going to have downstream effects on your hospital campus as well. So that's a big component of why we're doing this. I think it is worth noting that you have made significant investment in the growth of ambulatory sites over the last 10 years. So you really have grown that quite exponentially. So I think you deserve a lot of credit for the development of that over time. I think you've gone a far way in terms of getting there in terms of what you had and what you didn't have before. Some of those medical homes do have longer wait times, some are at capacity, some aren't, so you still have capacity. But as we look at this going forward, we're certainly going to look at the capacity issue. And finally, aggregating basic healthcare services in these sites. So creating these healthcare centers as opposed to sort of onesie, twosie primary care sites, that's really the goal of this. And I think if you see your model now, you've got a lot of that in place. So you have advanced practitioners there, you have RNs there, you have MDs there, you also have pharmacy services, lab, diagnostic, imaging, and a lot of other services. So you're starting to already see that benefit. So as I look at your model in place today, I think there's a lot to like there, and I think frankly you're ahead of the game in terms of a lot of similar institutions that we've seen like you. So I think that's a good thing, and I think it's a good model to carry forward. The next part, I think, to compare this to is looking at it in comparison to the main campus, right? Because this all started because of that, essentially the big ticket item of investing in a new hospital. So if you think of what are the benefits of this relative to that, first of all, you're reducing the need for many patients to travel those long distances, helping to alleviate campus congestion. You've got a real campus congestion issue just in terms of flow, patients going through it, parking, et cetera. So this ambulatory network plan will help to prevent that, not only by providing those services, but providing the preventative care that will prevent them from going to the hospital in the first place. The other benefit is, of course, outpatient care is delivered in a lower cost setting. Right? You made that comment about we're going to need some more bricks and mortar. You are going to need some more bricks and mortar. Bricks and mortar is a lot less expensive and a lot more costly when you do it out in the community. It doesn't have all the requirements of a hospital, et cetera. It doesn't have all the construction costs of a hospital, et cetera. So that's a real benefit of this. If you look at that, so that's that lower cost of investment. And if you just look at we took a look at your total billings. So right now, 28% of that is in JPS connection services. And then overall, 75% is in the outpatient. So if you think about where you're investing, just think about all the billings that are already funneling into outpatient, thinking about what your needs are on campus, and it really is around a main tower, a psych hospital, a lot of different things, but you can start to push some of those investment dollars off campus, given how much of your billings and how much your patient care is delivered in that environment. Better patient experience, again, that gets to that congestion issue. It just gets into the whole wayfinding, the whole experience of going into a hospital, which is very overwhelming for patients. You get them into those community centers, and it's just a much better patient experience for them. Finally, reducing overuse of the emergency department, especially for lower acuity, urgent, or emergent care. So we talked about maybe how it might, this is the one area where it really might actually replace some services. So you've got a huge amount of urgent care visits right now. You've got a huge amount of low acuity ED visits. Some of those can be seen in a different setting. And we're still working out, whether that translates into urgent care centers or just allowing walk-ins at some of your clinics. That will really be worked out over time. But just by creating that access and allowing for some of that, you're going to greatly reduce overuse in those areas. So I wanted to just pull up the population. I'll go through this quickly because I know you've probably seen population maps here before, but it really sets the foundation because as we think about ambulatory clinics, again, we're looking at the entire county and placement of clinics, and where does that make sense? So the first place you always start, of course, is the population. And if you look at this map, and they're using kind of a different coding system, but this is actual population size by zip code. So the blues are the highest, so that's where you get the most people per zip code. Then as you get down to sort of green in the middle, and then yellow and red. What this sort of actually paints to me is a picture of, it is somewhat sporadic, right? There's pieces in the center, there's pieces in the end. So it's really kind of just sort of highlights that there's really pockets of population all throughout your county. So usually we see a little bit more uniformity than we see here, but you've got a lot of pockets of population. And it really also says there's not, except when you get out on the edges, it's a pretty dense county overall. There's not a whole lot of open spaces until you get on the perimeter of the county. And if you look at population growth over here, a little bit of different picture, a little bit more uniformity. So you can see, what you can really see, what to me stands out right off of the bat is the center of the county isn't growing as fast as some of the other areas outside of the county. So you've got some down in Burleson and Mansfield. And I know Burleson can be a little bit of a challenge because it's a zip code that goes over the county borders. So we need to sort of work out what that means for you, but you do get patients from there now. And you can see some of those, those really denser parts in different pockets to the north, south, and west. Of course, as Greg indicated, we also want to focus on the indigent care, as you put it. Where is that underinsured population? So you can see that here. Of course, the bigger in this part, the center sort of does pop a little bit more, whereas some of those areas on the outside in the north, et cetera, you've got lower indigent care population. We usually do, so what this is a drive time map. So it looks a little jumbled here. Well, what you've got is all those, I forget if it's 12 or 13, but all of those what we're classifying as medical homes. And you've got a 10-minute drive from each of those. So those are all locations where there's primary care. 10-minute drive time is typically what we would consider for primary care office. On the edges of that can be challenging, especially during busy times. But what you see right away here is that there's pretty good coverage in terms of drive time. Now, that doesn't mean there's not wait times or capacity issues, but strictly from a drive time perspective, you've actually got most of the county covered, other than populations, say, in Mansfield, Grapevine, a little bit that sort of Saginaw area out into the northwest are probably the biggest populations. Now, does that mean we want to have access everywhere? Not necessarily. Some of those areas like Grapevine, for example, you have a much more affluent population, so you're going to have a much lower density of indigent care. So that will be a factor. So this doesn't mean we're going to try to fill all those gaps, but it's going to be one of the considerations that we're going to look at. I wanted to show you this one. This is actually a 7-minute drive time. Now, I think what this really does is highlight some of those gaps a little bit better. Again, remember my comment around the edges and busy times. Sometimes it doesn't, it's really almost not accessible for a lot of those populations, or at least it starts to create a barrier of where they're not going to want to go if it's, too far and too busy of a time. So in this one, some of those areas, like just north of the ring here, I think start to pop a little bit more. Maybe a couple in here. Remember, you're moving this one over this way a little bit. So there's probably a little bit of a gap there. They have access to services, but maybe not as convenient for some places. So as you think about how much you're going to grow going forward, I think this starts to help fill in the picture of possibly some areas we might target. Again, there's going to be a number of factors we look at, and actually you can see what some of those factors are as we get into that.
Where's that location right there by 20 and 360?
By
20 and 360 to the east?
20 and 360,
east.
so over here.
To the east.
Wrong side, sorry.
To the
20
east.
and 360, which is,
Go further.
Go further east.
In the light blue.
There you go.
oh, okay.
That's not a medical home.
That might be Barden.
That's not a medical home.
No, that's a good point. That is where you get your specialty care. So we did keep that up there because we consider the Barden Clinic one of your ambulatory care centers. So you're right, that doesn't cover the
Yeah, that's not a
population.
medical home, and it may not be there any longer.
Okay,
And you need to know that in the planning process.
okay. We will factor that in. We can take that off of the map. Again, we started from the basis of all your ambulatory care centers, which we would consider that. We would consider it a location you could potentially add primary care if you needed to go there. So that was why we included it
Yeah,
here.
that's more like a specialty care, right?
Yes, yes. Right now, it's all specialists at the Bard Clinic. I think at one time you did have family care there, but you no longer do.
Where does public transportation factor in here?
It does, and I actually had a map of public transportation that I pulled out mostly in the interest of time, so maybe I should have kept it in, but it does factor in. That is something we're gonna look at. That really gets into this access one, so that is one of the considerations, is the bus system. You know, what we don't know is how, and we can try to do a little research on it, but I don't know how the bus system is planned, what kind of planned expansion there is in terms of bus routes, et cetera, train routes, et cetera. But we have looked at that and we have overlaid that, and that will be something that we will factor in here, especially for your population. We are gonna, again, look at capacity. That's something we're in the middle of looking at right now. Also, main campus strategic integration and specialty needs strategy. So that will just factor in terms of, you know, what the plans are here impact the plans there and vice versa, as well as what the specialty needs strategy is gonna be. Available resources of real estate opportunities, that will really come in down the road. But to the extent that we know of anything you own that might be valuable, we'll certainly look at it in the context of this and see if that might, for example, impact the phasing of opportunities, et cetera. So we are gonna look to basically phase that in over time. And we're gonna come up with a plan that's gonna say, you know, year 1 through 3, here's what you do, 4 through 6, et cetera. So I wanted to give you a chart also. You know, again, we use these, we call them sub-markets. This was a definition that you've used in the past. You might not have as much recent familiarity with it, but it's really a way of segmenting the population so I don't have to throw 90 zip codes up to here. And you can get a sense of the different kinds of markets. What I think it does, and if you look at them, I mean, there's a variation. They're all around 100,000 to 300,000, most in that sort of 150 range. You can see the population of each of them. You can see the growth. This is interesting. This is that percent poverty level of 250%. So if you look at some of the areas where it's greatest, like Southeast and Central, right now that is where you have most of your medical home clinics, right? So you're already meeting those needs, and that makes sense given, you know, the size of those populations, as well as the targeted population. So you're already very strong in those areas, and of course those areas are also close to the hospital. As you can see, there's a great variation in here. You go, the lowest being the Grapevine CV market. So, you know, again, those will influence decisions we make going forward in terms of where to place these clinics. I thought ED share would be another good thing to look at. And by the way, we do have a whole, we use a whole evaluation criteria, a whole quantitative process that we use to score the markets, which we're working through with, and tweaking with JPS as well, to really, you know, get at a system that's really going to identify where you need to be going forward. ED share is one of those metrics. I think it's helpful to kind of understand. Remember, ED market shares tend to be a lot less than inpatient market share. So if you're used to seeing inpatient market share numbers, these numbers are going to look a lot lower to you. That's pretty typical. People don't usually have that because there's just there's a greater variety of services for that, freestanding EDs, et cetera, urgent care. And this is based on market estimates. So we actually use your data versus, I think, market estimates, and that gets you to the ED share. So that's why those numbers look lower. But you can see in some of those outer markets, especially, you know, you're a lot lower, which sort of gets to the question of, you know, how much is JPS as a system, you know, important to those markets? How much are they utilizing that? Now, I think if they have a high poverty level, those are still going to be target markets. But I think it's an important consideration to understand how much those populations are utilizing those services, and if it's realistic to expect them to use them in great numbers going forward. So that's the reason we look at those numbers.
So Sam, just to make sure I understand that completely, if I was to look at the top, excuse me, the top one there is Central. We're saying that 23.6% of the patients that utilize an emergency room in that central market came to JPS.
Correct.
And so 75% went to other hospitals all through the
Or
town.
freestanding EDs.
Or
You gotta remember
freestanding
the
ED.
level one trauma component is a big variable in that equation. Because you've got level one trauma attendees that wouldn't necessarily be going to JPS but for
Oh,
the
yeah,
level
I
one
know
trauma
that.
service. So
Yeah.
that, I think it slants that chart a little bit.
I'm just trying to figure out what I'm reading there.
Yes.
So 23% of all the people in this central market, when they picked JPS or they came to JPS versus 75% went to a freestanding ER or to another hospital, right?
Yep.
Okay, I just want to make sure I got that right.
Yep.
Okay, yeah.
And a lot of that's obviously driven by EMS and
Yeah.
the rules around that
Yeah.
as well. Then the next two columns are JPS AC, which is ambulatory centers. So those are those medical homes that we talked about. And it does include, as you can see in the footnotes, the Barden Road Specialty Clinic as well. But those are your ambulatory care centers that you have out in the market. We did add in the school-based clinics, but again, that's not really a part of what we're looking at here.
Do
The
we have any JPS freestanding ERs?
No.
No, okay.
Yeah, and we can look at where those are in the market. I know Texas is my sense is Texas is it's the biggest market in the U.S. in terms of freestanding EDs.
Yeah,
It's oversaturated. I don't think Tarrant County is as bad as some other counties, but
It's heavily,
Yeah.
yeah.
They're shutting their doors.
And
too.
well,
Some
I
of
was
them
about
are
to
shutting
say that
Mansfield.
a lot of
That's
them
right.
are
They are.
going down. These
Yeah.
doctor-owned ones that only take commercial pay, they're just not doing that well.
right.
And those are going
When the
down.
insurance companies are saying, wait a second, we're not paying full price for freestanding ERs anymore, so you're seeing a lot of,
There's a lot of.
I think you're
pushback.
gonna see some consolidation there. I was just curious if we have.
No, in this
Yeah.
market more than any other, and when I say market, I mean Texas,
Yeah.
you will see a lot of that shrinkage.
Yeah.
More so than probably anywhere else.
Yeah, okay.
So this last number is an interesting one. We're calling it PCB distribution. So what we did here actually was we took the 98 doctors, right, and we said, if there's a need for 98, how would we distribute that across these markets? And what the formula we used for this, we actually looked at your current population. We knew we wanted to emphasize that federal poverty level. And about 2/3 of your patients right now come from that, with about 1/3 coming from combined Medicare and commercial. So we want to recognize the reality of your situation as well, recognize you may get some of those patients wherever you put them, so I think it's important to factor that in. And frankly, that's not a bad thing for your system to get those patients, because it helps with, no margin, no mission. But again, we are focusing on the targeted population that you have to serve. So if you take that number, so we weighted it 2/3 towards that, and then we distributed across the market based on that. And you can then see, and there's some surprising numbers, I guess, maybe not surprising, but you can see, for example, North Central, North Arlington, you've got about the same amount of doctors, even though you've got almost double the population in North Central. And again, that has to do with the poverty level weighting. But you can see that distribution, and I think one of the messages that this says to me is that, it is begging for a distributed network across that. So anything here where you see a number, frankly, above 4 or 5, which is all of them except for 1, that's probably going to indicate, a need for some kind of presence. That doesn't mean there has to be one exactly directly located in each of those submarkets, because you can put one on the edge of the submarket that serves another submarket. But that's what that says. The next step that we're looking at now is we then actually look at your actual visits. So the way we look at how you're serving it now is the number of visits you have at these medical homes. We're going to take that number of visits and we're going to actually subtract it from each of those. So think of that as a need number. So this is starting with a demand number. This is sort of what the demand for your types of primary care in your market is. We're going to subtract what you're actually doing right now, and we're going to use that metric that HMA used in terms of PCP visits per doc, and we're going to subtract those out, and then you'll start to see some numbers that indicate, maybe what that need is by county. So the next thing I want to do, we've got a few of these slides. I don't think we're going to go through all of them, but I want to, again, start to show you how we're starting to break down this market. So we actually start with the quadrants, and then we're going to actually drill down within each quadrant to some of the sub-markets. But so we're starting here with the northeast quadrant. On each of these tables, we're going to show you where your facilities are located in, and this is the visit trend at each of those. So this is actually what you see is somewhat flat, but sort of steady growth up. I don't know the percentage of that off the top of my head, but it looks like you're at, what, 5% growth over a couple of years in both of them, although the second one had a sort of dip and then went back down. But that's probably pretty consistent with the population growth on an annual basis, because you're only going over 2 years here. Now, what you can see on the map then, these are the targets. You've got your drive time zones from each of the sites in the market, this one and this one. This little arrow shows that you're moving to the new location this summer. And then what we've tried to show is maybe some of these areas within this market where access strictly from a drive time perspective isn't good. You know, again, this comes up, but strategically Grapevine may not make sense. So even though it's showing access, we're not probably going to recommend one there, at least in the short term anyways. But just wanted to show you now which populations don't necessarily have access. You look over here, well, actually, I'll show you this when we get to that map. But you look over here, and it's kind of that upper part, even over here a little bit, where you've got some densities that are just sort of on the fringe of that range. So if you drill down, so this is the HEB market. So here's the profile for that market: 260,000 people, 5-year growth of 6.3%, median household income of about 62,000. You can see the sort of total visits of your total. So this market accounts for 6% of all your ED visits. It actually accounts for almost 10% of all your behavioral health discharges. We've got the school-based clinics. 2 of them there's actually 3. 2 of them are basically in the buildings next door, so they're sort of on top of each other there. And then some data on the Northeast Health Center. Again, this is relocating to the new location this summer. But I talked about that model of care, right? And this is in a 27,000 square foot building, which is a little bit on, I think, the lower side compared to some of yours. And maybe it's right about the median, but you do have some larger ones. This one offers pediatrics, women's health care, pharmacy, behavioral health, and most of them don't have behavioral health. But I think going forward, especially with the model of embedding behavioral health and primary care clinics, which was talked about in some of the previous ones, we'll look at that, dental care and ultrasound. So that is the current site. Again, it's moving. I think the other thing that helps with these maps, too, as you're going to see this more going forward, you can kind of see where those population densities are, right? You can see the rooftops. You can see the homes. You can see how the community, has some gaps in it and where that real dense populations are and what it's serving. So that kind of helps influence, again, where we're going to be actually looking at placement of sites. So this is the Grapevine market. You do not have one in this market. Obviously, the airport is kind of a geographic barrier there, so that population has to come down. Again, I don't want the takeaway here to be we're suggesting one in Grapevine, but if you look at that, basically the center of that population, the nearest clinic to them is the Northeast Health Center, which is about 10 miles or 15 minutes away. North Central Market. So this is the current site, the Gertrude Tarpley Health Center. It's in that plaza there. Big population for this one, huge growth, also almost 12% over 5 years. If you look at this too, one of the things we're going to think about is, and I'm sure you've experienced this living here, you can't just look at a map and say how far away is it. You have to, how far away is it? You have to look at all these roads. So for example, coming down from here, a lot of the Keller population can easily come down Main Street and access that. Someone say over here, it's going to be a little bit more of a difficult drive. So we think about things like road flow and patterns and how that works for people as well. Northwest quadrant. These are some of the areas that we're going to look at. This is the area that's called White Settlement. That's the sort of Saginaw and North. Those are going to be areas we're going to look at. Again, we're not at the recommendation stage yet, but those are certainly gaps in terms of access right now. And you can see some of the growth in the sites there as well. Pretty strong at that JPS Northwest clinic. That's the one actually all the way out there. So. Southwest quadrant. This one's interesting because if you look at that, if you just looked at the quadrant in and of itself, you'd say, okay, there's a big, this is the southwest submarket. If you just look at this submarket in and of itself, you would say a lot of population in Brenbrook, Crowley, but they're actually within that 10-minute drive zone. So even though there's not one specifically in that submarket, a good portion of that is being served. And if you think about that too, because of this population being dense up here, the west submarket's a little bit smaller. That site is actually really serving a pretty huge population, and I think this is one of the most aggressive growth lines you can see, going from 29,900 a couple of years ago to over 35,000 now. This is the southeast submarket. The reason you see that whole jumbled picture there is because that's where the highest concentration of your sites are, with the 10-minute drive zones. You can see some of those growth patterns. Some are bigger than others. Some are a little bit more flat. There's also been a lot of sort of movement in terms of how you've sort of reconfigured those sites, et cetera, in the last couple of years. But you can see potentially some maybe gaps in that South Arlington market as well. Finally, I wanted to bring this up. These are the FQHCs. These are going to be an important consideration. Those were talked about in your last one. We consider those as analogous to your sites in the sense of they're serving a very similar population. I think Greg made the comment before that relative to other markets, you really don't have a lot of those in this market. You know, we would like to see more, but it is what it is. They are opening a fourth. But as you can see, they've grown pretty good. I mean, 2006, 2009, 2015. So every few years they've opened a new one with a fourth on its way. But those will factor in because we'll consider the population in some of those areas served. However, right now, those are mostly in markets you've got pretty well covered anyway. So, any questions, comments?
Is the market driven by the chronic diseases that we have? Is that a part of it? Maybe that's a little naive to think. So, diabetes is a big issue
Yep.
for us?
Yep.
Or is the assumption that you can go to any of these clinics and get that service?
Yeah, I mean, if you look at the, you know, do you have, dialysis at these clinics? No. But, I mean, if you look at the community needs assessment report, right, certainly it shows a high prevalence of those. What I will say about chronic disease is one of the best ways to treat chronic diseases is through follow-up care with your patients. So even if they're not having, you know, a direct service necessarily related to their congestive heart failure or diabetes at these locations, and a lot of those diseases can be served by primary care. The important thing is to have frequent follow-up with those patients, frequent checkups with those types of patients, and this is what those facilities will provide that. So, but no, we don't specifically look at a specific chronic disease population and then target it that way. But we know from the community needs assessment, you know, where those areas are, and it's, I think, pretty consistent with the poverty level numbers as well.
On slide number 8, when you take out the Barden Center, you'll note that in regard to South Arlington, Mansfield, Arlington, period, you were talking about transportation routes and that kind of thing.
Yep.
And the T and all of that. Well, that area doesn't have that at all.
Doesn't have the transportation.
At all. So I'm saying that to highlight that.
Yeah.
So as you all do what you do,
Yeah.
in that regard, just know that that does not exist.
In your mind, what are the implications of that?
Well, one is there are going to have to be more access points.
Yep.
In regard, as it concerns those individuals. I know in Mansfield, you're looking at an indigent population of about 20% of that number. So, and of course, Arlington has a higher percentage.
Yeah.
So that needs to be taken into consideration. Yeah. I appreciate your presentation, though, because I think it highlights that, and I heard you say that.
Yeah.
And I'm glad to hear you say that. I think we're going to have to do both ends.
Yeah.
We need to give attention to the needs of the central location as well as the outlying areas. But then also we highlighted the fact that a lot of your emergency care facilities are shutting down, and those are fairly new buildings. You know, so we could save money in, I think. Yeah, oh, God, yeah, you can, rather than build them, move into them. Because they're real nice, they're beautiful, you know, but now they're empty and boarded up, you know, especially in the South Arlington, Mansfield area. So I think that's something that should be considered, along with something, again, that's quite obvious. We know what we need to do downtown. I think that's a given. But don't overlook those facilities that are already freestanding, ERs, urgent care facilities,
Yep.
already there, boarded up, closed up. For those areas, Tarrant, that have zero transportation, public transportation. that is.
Pastor Evans, I have a quick question for you. For those, or I guess this will go to GK or the chairs as well, co-chairs as well. Is there a listing that has all of those different locations that are boarded up, that are available for that type of, what you're proposing? Is there a listing of that somewhere?
JPS might have, mine, I know we don't, at Bethlehem.
It'd be pretty easy to find.
Fine, yeah.
You can get it.
I'm sorry, I'm not understanding.
There's
Didn't
ways
hear
to
you.
find that.
Yeah, there are ways to find that.
Okay, so is there someone who,
Yeah, good question.
part of JPS that can help us get
Bring
that? I
it
feel
to
like
us.
we're here, so can someone help us with
Look
that?
at it.
Or can the consultants help us with that?
We'll take
We need to look at that. I think that's, so here's the thing, is that we're talking about repurposing, utilizing facilities that are already there. I'm hearing a lot about costs, I'm hearing a lot about partnerships, so we do need to see existing measurements that are in place. And Pastor Evans, the only reason why I looked at you to see what the listing was because you were so articulate in explaining that there were vacancies, but absolutely, I agree with you. That's something that should be brought to this citizens committee so that we have a full understanding of of various remedies. We want to be cost efficient, but if we're not aware of things that are measurements that we can take to reduce, reuse, recycle, right? We need to do that. And I think I can make a better assessment, understanding all parts of Tarrant County if we knew what are viable structures that are in place that are underutilized,
Yep.
that we could invest in potentially, not saying it's a
Yeah.
promise, but could be cost efficient, and that way we have more money maybe to invest back in the hub.
Yeah, and one of the things that I meant to make this point earlier, it is important to note that, you can expand some of your current locations. And when we talk about meeting the needs, it doesn't mean you always have to open up a new building, right?
Absolutely.
So you can go in, you can expand in space, and that's where I got to that capacity. When I say capacity, I did mean mostly, the physicians, the capacity that they had to take on more patients. But it also does mean the building. Does the building have the capacity to take on more doctors and more patients?
Absolutely.
And some of your sites, you've built from the ground up. And I know you've got enough land. There's one that escaped my mind because I get them confused. But I've been to almost all of them, and we saw one on the tour. I personally have driven to everyone out there in the market, so I've seen them. And I know some of you have land you could potentially build up, right? So you can build another unit rather than having to build a whole new building and just sort of expand services that way. So the reason I actually went back to this slide was because we talk about this market over here and just sort of the huge population and the huge needs. At some point, that clinic in itself isn't going to be enough to serve the population.
Absolutely.
Now, maybe you expand that one, but if you look at that one, that's the top one. I mean, you added 7,000 patients in the last year alone. So, that's the one I look at going forward, even though it's got your most visits now, and I know I believe it's a relatively newer site, big site, you're going to need some solution. And the solution doesn't necessarily mean you have to put another dot there. Maybe it means growing that building. But that will certainly be a factor that to be considered going forward.
Question to that point, when you're forecasting, we're looking at 20 years out. I mean, you can obviously look at historical, here's what happened the last year, or 3 years, or 5 years. But when you take into consideration, like Hazlitt, 15 years ago, there was no Hazlitt. Well, now there's a big town, Hazlitt. So how are you using the aging of the population or what to forecast what percent is 250 of FPL in a particular zip code? In other words, you pick the older parts of Arlington or Mansfield or the newer growth areas but lower income.
Yeah, I mean, we have those numbers. I know we have the, going out 30 years. I mean, we have that on the zip code level. So, we can do that at a zip code level. In terms of trying to kind of figure out, I don't know if you're getting at within a zip code sort of which neighborhoods you focus on. you know, it's hard to really get that other than sort of looking at a map and just knowing where there's development and sort of seeing where they're going. You know, some of that we hear anyways. You know, I think, you know, our work won't get to that level where we're gonna say put a site here, we're gonna say put a site in this zip code. So, and you'll have the time over the years to sort of figure out where within that it makes sense, but it will factor all those things like the 30-year growth, the growth of the FPL under 250. So all that will be factored in, and then when you actually get to the point of building it, that's where you're really gonna look at, you know, some of those nuances within each zip code.
Thank you.
Well, it just occurs to me, we're talking about some things here. It's a brave new world we're looking at. In the old days, the idea was we're gonna build a county hospital and we'll put it down there on Main Street and folks are gonna come down. And now you've just showed us statistically that 75% of those folks are out there needing care in the periphery. Guess what? That was then, this is now. So the task ahead of us is to not just build a $1 billion facility on South Main. The task is at least twofold. And then I'm gonna echo Commissioner Wynn when he says, who's gonna run all this? Great thought, because we even have to look at how, it's gonna be a different deal, altogether different.
Do it.
Yeah, and remember, you funded all these clinics through, out of your maintenance capital, your operating capital, your ongoing capital, so, you know, you haven't had to go, you know, that hasn't had to be a bond offering yet, right? I mean, it's a strategic decision maybe whether you want to include some of that in or not. I'm sure that'll be determined, but I just wanted to point out that so far you've had this good growth without having to go, you know, to the community for bonds.
How do you handle primary care? Have you looked at that?
Well, that is what's driving that. Again, that number 98, that is the primary care number that we're using as the basis
But my
for the
understanding
clinic.
is primary care provided at these medical homes? Primary care
Barton's the only
services-
one. All the other ones have family practitioners, nurse practitioners, physician
Okay.
assistants. So yes,
So
everyone
primary care
except Barton.
services all provided at most of these facilities?
Yes, yes.
Okay.
They're all very similar. That is frankly the core service at all these facilities is the primary care. I mean, pharmacy is a big service at those as well, and some of the diagnostic services that they offer. But at their heart, at their core, they are primary care buildings. Now, some of them, you know, again, part of the conversation is you want to supplement some of those with maybe timeshare specialists going forward. And that's something we're gonna look at, but I think that's probably down the road, and that will be essentially something you would piggyback on existing, medical home clinics or primary care.
Is the telemedicine technology, is it mature enough to be included in the long-term planning?
Yes and no. I mean, yes, yes, it is. Where there's still a lot of debate is what kind of impact does telehealth or telemedicine have on bricks and mortar? And to date, there hasn't been anything conclusively to show that it's had a huge impact. There's still a lot of speculation that it will, but right now, a lot of telemedicine, telehealth visits, you know, are you know, things like dermatology is a big one, even behavioral health's a big one. But they tend to be more additive than replacement. So you're sort of, you know, you're adding or complementing a service as opposed to taking away a service. Sometimes you might have one and think, oh, that's going to be my primary care visit, but then they diagnose something and then you got to go and get the visit anyway. So again, it tends to be, at least today, the evidence shows it to be more additive than replacement. And so, you know, we can look at projections out there. Again, there is speculation that it's going to maybe decrease that a little bit. So two things, you know, you could maybe, you know, I wouldn't be comfortable, frankly, knocking more than 10% off your need. You know, but at the reality, remember, we had some of this conversation earlier, you may not, those numbers are so big, you're probably not going to get there anyway. So it's a question of what's enough to, you know, adequately serve your community and using those other things to get there. But the other point I want to make is you do want to integrate that as part of your strategy. You do want to take care of telemedicine. I know there's already, Scott and his team have looked at, for example, in urgent care, sort of telehealth, maybe taking some of that. So that is a strategy you're going to want to integrate in that clinics, but it's a matter of really integrating it into your operating protocols, et cetera. You know, in terms of the actual physical space for that, you know, you should be able to accomplish that in the sites that are already there.
But it won't significantly reduce our unmet need.
Yeah, I mean, I would just add
Yep.
in, I would say there are some, technologies that will do that. The telemedicine itself, where you're having a visit that the provider and the patient are in two different places, really helps with access.
Yep.
It doesn't help drive down the need in terms of primary care or specialty. There are other things which are similar, like e-consult, where it's asynchronous, and you're having really the asynchronous in time. You have the visit as a primary care provider with the patient. The specialty question is brought up, and that's done at another time by a specialist, and who is answering the question and brought back into that primary care relationship. And it decreases overall the amount of specialists that are needed. So it's not that telemedicine is bad and e-consults are good, they're just solving two different problems.
And again, it helps with chronic, it helps manage the health of your population. So, it will, in the long run, have a downstream effect on people going to the hospital, for example. So it will, that's one of the things that should help, reduce use rates, inpatient use rates, et cetera. Can you conclusively put a number on that right now? Not really, but, again, my sense is, especially with beds and stuff, you're gonna reach a certain point that I'm not sure it's gonna impact your planning going forward. It's gonna impact your operational planning and your service line. It's gonna operate your planning in terms of what you need to do at these sites. It's not gonna, I think, impact the planning in a big way in terms of how many clinics you need to build and how many beds you need to build. If that makes sense.
Yeah.
All right, I think, any other questions? I know we're right up on the time.
Okay, Sam, thank you.
Thank you.
Do you want to talk about the revised schedule?
Well, let's be thankful for the presentations today. Thank you, gentlemen, you were quite entertaining.
Or depressing.
Or depressing, yeah, one or the other. We've had lots of discussion. I think that the staff have in trying to get us to the point here so we can hone in on our deliberations. And so there's some discussions of trying to revise our schedule a little bit and probably do these, you can tell from the amount of discussions we've been having our last couple of sessions that we're getting into the throes of this, and it's getting complicated, it's getting interesting, and I think all of us are getting more involved in what we're doing. We're thinking of the next couple of sessions, Candace, right? Doing our sessions a little longer, with the hopes that we can have these robust discussions, come to answer some of the questions we have now, and we see in the future to get us to the point. This is all, if you talk to GK, all he wants to do is give us the information and get us to the vortex where we can make some recommendations. Correct, GK? Did I misrepresent you?
No, that's correct.
And so the thought was that our sessions could be extended, and I think we wanted to get a sense from each of you how you feel about that. An additional hour?
Yes, on the sixth, June 6th, it would be until 5:30, and on the 23rd, it would be an additional 30 minutes. So it gets you out there around 5 or 4:30.
So it's not a whole lot of time, but I think this will help us at the end to make a much more informed decision. So how do you feel about it?
Madam Chair, as long as you invite us to a happy hour afterwards.
I stepped in it. Okay.
And agreeing, the cookies are here now, everyone, and the cookies could be here earlier. And if the cookies are here, we'll last longer.
Okay. So what do you think, though, seriously?
Sure, let's get her done. I mean,
Okay.
time's a wasted.
I'm with that, but why not an hour earlier? 1:30 rather than 2:30 and to get out of here at 4:30 rather than 5:30.
It's okay. Yeah.
It's okay, it
I'm
just,
just asking.
you know what,
Sounds good.
and I appreciate you asking, I think we're kind of creatures of habit, so we've been starting at 2:30. And once, that's why we were asking when we started, is 2:30 where we wanna be, because that's when, what,
And maybe to dovetail to that, 5:30 means some of us that are traveling east are right in the middle of a rush, so we might as well go to 6.
well, then
What
we
I'm saying
can,
is,
yeah,
you know, it's one
GK
of
can
those
get
things
you a
where
helicopter, so you can.
either 1 to 4:30 or 2:30 to 6 or something, just, I mean, what, otherwise.
Right, because you've just got
30
dead
minutes
time,
that you
and I've
get,
got dead time going up northeast
Exactly,
too,
so it's kind of, we can
yeah.
work around.
1 or
the rush.
1:30, I think is a good
See if we can
idea.
get a consensus.
Well,
I'll go with whatever
or
the
live
committee
in the
decides.
center city as I do, and it's a 6-minute drive.
Not an option for me.
We'll welcome you in the historic South Side,
That's-
you know, you're all welcome. So the consensus is we try to, 1,
I would request 1:30.
1:30,
1:30.
1:30 going once, going twice.
I'll do it for
So,
y'all.
at 1:30 for our next 2 meetings, okay?
Okay, just those two.
Just us two though.
Yep.
Okay.
Is that okay, everybody?
I'll sacrifice.
D,
Our northeast and east folks.
And that's May 23rd and June 6th, is that right?
yes,
Yes.
sir? Yes, May 23rd and June 6th.
I know that we're providing a tremendous amount of information to you, and it may be somewhat of an overload, but we're also trying to balance, there's a tremendous amount of information, and quite frankly, we'd rather give it to you more in a big load than stretch it out so that, you know, I don't know about y'all, but after a while, I forget what I was looking at, you know.
Sure.
Way back, so we can get it here that way, and hopefully that'll coalesce into a greater vision for you all to come up with recommendations. We really appreciate
Oh, yeah.
Yes, we really do.
Well, we all made a commitment to do this, and I sit here and listening to the presentations today, and you think about the unmet need. It's the people
Yep.
of Tarrant County that we're trying to
Take care
help.
of them.
Yeah,
We're trying to take
and
care of
then
them.
if it, we have to. I think it's a worthy venture to invest the time, our personal time. So. Okay, D.
Yes, ma'am. I'm just
Okay.
following your lead, whatever you say.
Uh-oh. Okay.
Good deal.
All right.
All right.
With nothing else, GK?
That's it.
I noticed our
Pick up a cookie.
our
and went out.
judge came in and left. That's a good thing, huh?